Hi everybody. Yeah. It's 10 o'clock, so I think we should probably make a start. So Georgina Parks is speaking this morning first of all about trauma in learning disability and ASD services. Is that right? Presentation.
Well, just in people without the yeah.
We just get people to sign in.
Oh yeah.
Oh yeah, everybody.
That's right.
That just reminded me when you did that, I think there was a survey of people with learning disability, what do you want to be called? And they don't like PLD, PID, we just want to be people. So I think I'll just refer to people as people, but as we there, I'm talking about people with intellectual disabilities in particular in this talk. Okay, I'll try anyway. All right, here's the liner. Okay, so how do we diagnose? I've even written it wrong there. PTSD, not PSTD, and complex PTSD. So start off with what's trauma. I mean, people probably know what trauma is, but trauma itself is an event, but it's how that affects you. So it's actually psychological effect of that event, and so it affects everybody differently. So everybody might experience the same event. For example, if you're in a an earthquake or something specific that's happened to everyone, but it's the psychological impact on you that would then be called the trauma, not the event itself. And I think from my point of view, I like to think about it as an unprocessed fear. It still lives within you. And Freud talks about it as being a foreign object lodged in the brain. And I find that image quite useful as well, because it's there and you've developed around it, and you might try to forget about it. And then years later, something else happens. That thing is still there and it comes back. It's just an image which is helpful, I think, and can be difficult to process these fears, because we have all different systems that triggers when we're afraid. And they're different. For some people, we know the fight or flight ones, but what we realise is with more severe traumas, and also the more traumas that you experience, it is more likely to go into the freeze mode. So that's more likely as you experience more traumas. So ICD-11, which I still haven't really got my head around, I still use ICD-10, I don't know if anything else does, but anyway, this is ICD-11. They just have these 3 symptoms, which do align with ICD-10, so it's actually not any different, which is good. But it gives you more of a flavour because it's a current threat, re-experiencing, avoidance of reminders. In ICD-10, you had to have a history of a traumatic event, and that was problematic for our patients because quite often we don't get a history, or even for other people, that event that happened 40 years ago or even longer than that. So it doesn't get related back to what's currently, happening now. And you have to sort of be able to do a bit of detective work, really. But in ICD-10, to get PTSD, actually, those symptoms, most people might have had one traumatic event. So, for example, over 70% people had had one road traffic accident leading to PTSD. So it was all set up for that, really. And there was no sort of formulation about the differences of childhood traumas in the developmental phase of your life, about chronic trauma going on over years with an attachment figure, or there's so many things that are different. But this is all just set up really for a road traffic accident, and they are different things. Although you usually get some of these, like I said, it all can be buried and murky and a bit more difficult. So it's good that there's complex PTSD, which helps us think about it a bit more. So we still need those three, and then this affect, dysregulation, this emotional numbing. And I think this is difficult because what you find is patients come in and they get discharged. Why do they get discharged? Because they're not showing any affect, and people say, oh, they're fine. Or they get, you know, people, they might represent, and people might get a bit annoyed with them, but they're not showing you any emotion necessarily, and they might describe an event with no emotion. And instead of your mindset saying, oh, they're okay, or perhaps it didn't really upset them, actually that's showing that it is more serious. That's more serious. And so that emotional numbing, you know, try not to, the counter-transference feeling of disconnected feelings that will come with that when you see somebody who's got it. It's real, you will feel disconnected from them. And that can lead you to discharging them. So I'm just saying, please think about that. Why am I feeling disconnected? They're describing something, or these things are happening. Actually, this could be severe trauma that we're talking about here. And it also can happen in relatives, you know, like the mum or family coming and telling you these awful things have happened and they're not upset. That's because they're suffering trauma from, you know, the things that happened and that they've had to deal with as well. And there you have, you know, the only way to survive to cut off. You can't be constantly distressed. You just can't live like that. So you have to cut off from your own feelings, and that leads to the clinician feeling cut off as well. So yes, so difficulties in forming and maintaining relationships. So what you can see here is that overlap with what we would have said traditionally borderline personality disorder. So that's becoming a rarer diagnosis actually, because there's also an overlap with ADHD with borderline personality disorder. So you're getting a much sort of moving away from actually diagnosing someone with that, because you'd be saying, like, what's really going on? Could there be something else? And that negative self-concept, that's very difficult to shift in an individual, and that can be why the therapy might be difficult as well. You know, that feeling of I'm not good enough, and the shame, the guilt. So in people, well, I have to say, in all people, not just people with learning disability, the etiology of complex PTSD, so like I say, what you're actually talking about is an inner symptom, psychological symptom within that person, not the actual trauma. Is down to these sorts of things. So prolonged exposure, which will affect the concept of self. People with intellectual disability do find it difficult to develop a sense of self. There's not really anything written about it, but when you're doing therapy, you know, people in general, people don't have a full, well-formed concept of themselves as an individual. And that, you know, there's a lot of reasons for that, but partly it's dependency, dependent on other people. So to separate yourself as an individual can be quite difficult. So they've already got that anyway. So they'd be more likely to develop complex PTSD if they suffered an, you know, traumatic event. And there's also things around autism and ADHD. ADHD is saying, you know, if you get a lot more negative memories just kind of pop up out of nowhere, so you might re-experience that trauma much more often. Somebody who doesn't have ADHD, so you might be more likely to get complex PTSD than someone who doesn't have it, who suffered the same event. But also memory can be an issue. in terms of therapy, because people with ADHD don't have a good working memory quite often, so might not remember what they've talked about in therapy, go back and you have to start again. So, you know, it can be much more difficult then to get the treatment and the help. It just takes longer, basically. But that is the same with people with learning disability. And there was one study, there's one individual person study, if you like, about somebody who didn't have a learning disability, who had poor working memory, and how she struggled in therapy because she couldn't remember what they talked about. And, you know, it was about developing an external working memory and being flexible in the therapy so that, you know, she could take notes, talk into the phone or whatever it is. So yes, all these things, prolonged exposure, a presence of ACEs might lead to complex PTSD, but of course a lot of ACEs are very traumatic events, aren't they? If you suffered physical abuse or you know, there's only 10, aren't there, but they're all quite difficult things. And I think that's, well, I could go into all sorts of things, but there is a study about people working like care workers in America, working with people with learning disability, and they were kind of divided up into two camps. Those who stayed for under a year, those who stayed longer than a year. Who stayed longer than a year, they've usually stayed longer than 5 years. So, you know, they sort of carried on for that year. But in terms of their number of ACEs, they were much lower in that group that stayed, and the group that left had much higher numbers of ACEs. And you know, because it can actually trigger quite a lot of things in the individual, so we do need to think about within ourselves, you know, because we work with a group of people who can't always talk about things, so they might act it out, might be violent or aggressive. There might be quite a few triggers going on there that might affect us if we've got high ACEs. So we might need to think about that. In direct work, you really are directly close. I mean, I know that I couldn't work directly as a support worker with somebody because learning disability. I find that very difficult, but I can do what I'm doing now and I'm at arm's length. So anyway, it's not a single catastrophic event. You wouldn't normally get, that's not normally thing, but it could be that might have triggered off then something that's happened to you in the past, which you've forgotten about, you were living with or whatever. Okay, so so maintaining facts they've talked about is if you don't want to talk about it, which again, a lot of our patients don't want to talk about it. Well, I'm working with teenagers, they really don't want to talk about it. You know, just get up and slam the door. So that again. But it is a maintaining factor, so it is something to think about. What we know from this Truth project that was about for the general public, and it was run by the police and government. It's part of the child sexual abuse programme, the national investigation into child sexual abuse. The Truth project is for anybody who could ring up and talk about something that happened to them at any point in their life. And what they were saying, you know, it's all abusive experiences. People who talked about that were age 30 to 50, people who rang up those lines. So if we're thinking, you know, people used to say, oh, why are they talking about it now? That happened 30 years ago, or whatever. That's actually normal. That is when you finally can think about it. And you finally got enough, I don't know, you want to do something about it, you're not just pushing it away. And so actually up to the age of 30 is just not as common for people to tell you that they've been abused, and yet they might be suffering a lot of range of mental illnesses because it's all connected. So it is normal. It's not like, oh, they tell you it happened 2 weeks ago, they're going to tell you now. They don't. So we talked about memory. Yeah, so this is from like just looking through the literature, what symptoms do people with learning disabilities have that have PTSD, and it's sort of aggression and anger, and I'll say that's number one in terms of presenting to services. That is the number one symptom. So anybody with aggression and anger, think about trauma, think about PTSD. It might not tell you an event. It's very rarely going to tell you an event actually. But eventually you might get there if you sift through, if you talk to other people, if you try and get, you know, information, or sometimes you just ask them, but you don't necessarily ask them on the first time, you know, but have a suspicion, have a thought about it. They're presenting with anger and aggression, because that is the number one presenting symptom. Sleep problems, restlessness, you know, it's all this sort of nightmares, but again, it's very concrete. That's what I meant, it's got quite concretized. So I mean, talk about cases that, you know, now that I'm doing inpatients, work with adolescents with learning disabilities, inpatients, you sort of see it a lot more live, and things that I wouldn't have seen in the community, and obviously with the younger ones. But you know, somebody who can see difficulties, we all see difficulties, it's all autism anyway, some ADHD, etc. But you know, suddenly from sleep, fast asleep, because we've done one-to-one odds, being observed all the time, from sleep, jumped up, strangling the one-to-one worker who was sitting outside the door. Now, that is a trauma reaction, but it's very concrete. It's a very concrete reaction. He was still asleep. That's what the worker said. He was still asleep. He hadn't woken up. So, you know, it's not like, well, I'm having a nightmare, you know, but just this, he, you know, having a nightmare that it's being attacked, presumably, but you never get any information about it. So it can be quite difficult, but we can see it much more. Sexually inappropriate behaviour. I think this is much more in sort of older people. That's what I saw when I was in the community, like older people who've been in institutions, and you know, it's like normalise their behaviours which are not normal, and you're coming in for the first time and saying, you know, why does he keep rubbing up against the other resident like that? That's a crime, actually. You know, that's a criminal behaviour. And what's going on? And I actually just asked his, because he didn't speak, his mum, spoke to his mum at length, and she believed he had been abused in a long stay hospital years before. And he'd never done that behaviour before he went in there. But you can't know for sure anything, because people are not going to tell you. But you know, it's not a normal behaviour, and it's unfair for that other person who's now been traumatised, because you know, they're having to live with somebody who's sexually assaulting them all the time. So it's quite difficult. I think you have to keep thinking about it as well. Keep an open mind about this and ask the questions, which it's hard, and you can't just go in and ask the question. You have to have a conversation first and build up some trust. But don't ask, you know, nobody had asked that mum before. She said that's the first person that ever asked for that, but at least it gives you an understanding for what's happened to this person, what can we do, you know, to help them move forward. So I've also forgotten to put in the other experience. I've said in my experience, you don't get the history of the event, so that used to always rule out getting the diagnosis, but we're not going to rule it out because of that. We get claims of, you know, people saying they're being abused when it's not happening. And again, now working in inpatients, I've seen it live happening. We've got CCTV and we can go back and review it. But you know, when I was working with adults in the community, and you know, I had a patient, I'm looking at Eileen because she knows this patient really well. You know, and she went in hospital every year, 10 years or something, and then I thought, all right, next 3 nights, right, she's got bipolar, right, get her on the treatment, didn't go into hospital. Why I'm still getting phone calls from the home, emergencies, this, that, and the other. You know, calling 999, such a point during COVID. I was having strategy meetings with like the ambulance service, the police. They're all saying she's wasting all this money. We're only responding to COVID, you know, and saying that staff are assaulting her all the time. But then there's a real quality when they tell you these things, and you can feel it. Like there's a real quality that's really happened. And that's why that can lead to like splitting as well within the team, because people know it hasn't happened. But other people will believe because there is a quality, because it's based on a real event in the past. And the person themselves, what I've seen now working in the hospital, the person themselves have actually believed that's happened, and they tell you like it's really happened, and it's again very concretisation of a re-experiencing phenomenon of PTSD, of the trauma, but it is presented as I'm having a flashback. That is not how it's presented. It's presented as this has happened. So then you know, then if you can get into that, because I don't know, I've worked in various teams, and we always have one or two that are like this, that phone police all the time, or, you know, make false allegations. Always think about complex PTSD, and then you can ask the person, you know, and when I asked her about it, yeah, she had been, you know, she told me 2 occasions that happened, but also, you know, she had an alcoholic father who was abusing her mother. I think she'd come back to visit from the care home, and the mum ran into the bedroom, locked herself in, and died of a heart attack. And she was 20 hours in the patient. Then, when I was seeing her, she was in her 50s. She'd run round to the neighbours to get help, but didn't realise her mum basically had died, and this trauma, you know, stayed with her for a long time. But there were other traumas as well that happened. But, you know, you don't connect everything together. It doesn't mean you can necessarily change anything, because it's very abusive to everybody who tries to do therapy. So you have to come at it from a different angle. So these are the things that I've seen. Also dissociative seizures, and again, it's good when in the inpatient ward and you can see it and change it so quickly, can change that, because it's about you know, going with the staff and going like, this isn't an epileptic seizure, and what it's about, and and gradually, you know, I mean, this young lad's been with us for a year and a half, so it's a long time due to delayed discharge, but actually helped him incredibly, because he's then able to start by asking for PRN, which thing, well, that's not great. Well, actually, that's better than him having a seizure. Going to hospital, when it came to us, he was on toxic levels of anti-epileptic medication. He kept going into the local hospital and being treated there. You know, it's the neurologist that put him on all this stuff. And we gradually got him off everything, off all anti-epileptic drugs. Over that time, so it actually helped him a lot to be a delayed discharge. But you know, and it is more difficult, I think, with epilepsy when you're in the community. You're a bit more worried about that, I think. You know, we've got that 24-hour support, so it was a good time to do it. But yes, so anybody who's having dissociative seizure, then think about trauma, because otherwise, why are you having that? And I was supervising a trainee who was doing therapy with a patient, and she had a first session with this patient. She came in, she said, I'm having one now. And she said, having what? You know, what? A seizure. It's a number 2. Number 2. Okay. So, you know, gradually over the time, trying to figure out what's going on here. It's obviously that wasn't an epileptic seizure, but she's thinking she's having it. And we, you know, it took a long time. Well, it took less than a year, but she did then talk about when she was 3 years old, she got a status epilepticus being admitted to hospital. And I don't think she remembered it, but her family talked about it and remembered it all the time, and they were traumatised by this event. And they kept her in cotton wool because of it. I mean, she was in her 50s as well, but she stopped having dissociative seizures after the therapy. But you know, once she, so I kept saying, "Where's the trauma? We need to find it. I don't know where it is or what's going on here." But you know, it took so long for her to get to that point and talk about it. And it's the whole network that was keeping that going because they were all traumatized.
And the penultimate point, in your experience, once the claim or allegation has been found to be at least likely to be false, or there's a pattern of these false allegations, how do you acknowledge or respond to it with a person?
Well, that's difficult because they believe that's happened. I mean, we obviously got CCTV and we have social worker and the nurse, and they needed to say it didn't happen with CCTV, but they're aware that it's upset you. Or sometimes there's a grain of truth in it, you know, like somebody was sticking their tongue out, but they weren't doing just, you know, these other things that it said. But in the community, these people need 2-to-1, or they have continual placement breakdown because the placement's always having to be investigated and the staff are getting suspended. And so it's about figuring, talk, you know, you have to do a full assessment. I'm not doing this just like, oh yeah, we're going to do this. No, you have to do a full assessment to work with everyone, a big network. And at the end of it, you say, right, this is what we're going to do. We're going to have, you know, we're not going to totally investigate every claim. If there's a reason that it can't have happened, like there's 2 staff there, for example, or that we know that staff member wasn't working on that day, we're not going to do a full investigation because they would normally do still, social services would still do a full investigation, even if we know the staff member accused, this happened last night, we know they didn't work last night, they would still have to do it and suspend them and all this. So, you know, with these, where you can say obvious thing that we know it didn't happen, we're going to log it, talk about it, meet as a network, but we're not going to suspend this staff, because the other thing that's happening is once you start suspending staff, etc., staff members leave, they don't want to work there. You don't want to be accused. So you have to always, they are more expensive because you need 2 staff all the time. Or they can be in their own flat on their own, some people, but if you go in, you have to go in with 2 people to like help them with whatever it is. So, you know, or you might have some, you know, you have to have your own internal policy as well as then what will we do that we then will go into this investigation. And that's helped, and because we had somebody that was being repeatedly, you know, moving, and then they came to us out of the blue, and it's very severe. Well, it was severe trauma over, we don't ever know what it is, to be fair. But you know, he was a twin. His twin didn't have a learning disability. You know that he was taken, you know, to have exorcisms and things when he was young, when he was a child. It was very scary. He was very frightened of that happening again. There were things that he said about his family, but were never approved. Things that they'd done to him. But then when he did visit home, things were happening there. The police were what it's called. So, you know, we've had some idea. It's enough to say this is complex PTSD. You're not going to be able to go to court with most of this stuff. But then you can say, right, this is what we need. And we did that, we worked with the network, stop the staff getting suspended all the time. And he was going to move, they served notice, and eventually didn't move. They decided to stay there. They got on with him, they liked him, you know, and could work with him within this framework. So it's difficult, but you can help people indirectly, don't necessarily have to do direct therapy, because people were not going to engage with it. You know, they don't know what it is that's been traumatic, so they're not going to say, oh, this has happened, so I want to talk about it. It's a bit different. Why is it not working now? No. See if I can do it. Yeah. Oh, it's frozen. Sorry, it's frozen the screen. I don't know how much. Oh. Don't know why. No, it's frozen. It must be. It's just yourself. You've changed this. Did it change it? It's changed, yeah. Okay. Right, battery feature. Yeah. Yes. Where's that come back to? Yeah. Oh, that was just, so I was just saying these still things again. About the no history of events. The trauma might be events and stuff, traumatic event rather than trauma there. Might be many years ago, so it's just summarising. Family might not link anything to what's happened before. But also this last one I've put in here, PDA, so we don't know a lot about that, I suppose, but again, now that I'm doing teenagers. So persistent demand avoidance profile within autism is thought to be due to extreme anxiety, and you know, certainly person that I, you know, the young boy that I'm thinking about is due to his extreme trauma that he's suffered, you know, different traumas. And you know, it's because they want to control everything, so to make everything safe, I'm in control, I have to do everything. But it's so extreme, you won't do anything that you ask, so everything is indirect. But it's kind of a new thing. There's not any research necessarily, but from my point of view, somebody's coming with that, it's anxiety based and considered trauma. So this is the other disturbing thing. That's one reference I put there. There's people with ID. I mean, they've experienced multiple traumatic events in their lifetime. So not just one, it's most people that say with ID. So, you know, if you're going to school with other kids who've got ID, they might have, you know, an epileptic fit in front of you that you find traumatic, or they might get pinned down and you're witnessing that. You might get assaulted. This is what I'm saying about, you know, you don't have to be the one who's sexually abused necessarily. You might be the one who that traumatized person is, you know, hitting out, and you're getting that. And I've seen that because I'm taking adolescents coming from school. Most of those kids have attacked peers that we're admitting in their schools. So you've got a lot of traumatized kids with ID that become adults. And you know, they're witnessing that and they're having multiple traumatic events. It's not just the rare person. But also, as you get older, you know, you've got multiple physical health problems. You might experience a near-death experience. A lot more people with ID experience near-death, where they go in hospital and think they're going to die and they end up coming out again. But you know, you will have people on your caseload where that's happened, or you know, they might have a urine infection, doesn't get treated. They end up with all sorts of things going on. And a near death. You know, it doesn't have to come from anything major. It just can be like minor things that they're not picked up or treated properly. So all these things put you at high risk of complex PTSD, presentation, and So there is, thinking that having a learning disability is traumatic within your family, and it is. If you think of yourself, you have a child with a learning disability, that is traumatic. That would be traumatic. You're expecting a healthy child, and you don't get one, and there's grief within the family, and incredibly high levels of divorce in families that have a child with a learning disability. All these traumatic events add up. They're not just in the person that we're seeing, but within their families and their networks. And that can perpetuate it. Epilepsy, as we talked about before, but also trauma leads to more mental illness. There's a lot of research about that. It's all kinds of mental illness, not one in particular. Anxiety, depression, in adolescence, it's anxiety, depression, self-harm, suicide attempts, those sort of things. But as we see, it can also trigger major mental illnesses, and we see that schizophrenia and bipolar. So, what we're seeing, when we talk about someone with complex trauma and say, well, they've got this and this and this, yeah, that's actually more likely to be complex trauma. If you've got 5, 6, 7 diagnoses and a physical health complaint and autoimmune, then you probably have that complex trauma as a child. It's linked to, they've done loads of massive studies about ACEs in North America. And, more ACEs that you have, that's linked to physical health problems as an adult and mental illness. The only direct one is substance abuse, but all the others, it's not just mental illness. So autoimmune disorders, incredibly common if you suffer traumas and ACEs as a child. And so body attacking itself, those. And we know that people with learning disabilities are more likely to be sexually abused. I mean, the numbers vary, but it's still much higher than in the general population. And they might not be able to get away from their abuser, and read various papers. And I've seen it in my clinic. I've had a man who'd been through forensic services actually, I was seeing 2 medical students, and he suddenly decided, he never told me before, suddenly decided to tell medical students about being sexually abused by his dad, about his dad hits him over the head with a hammer. That's what caused his learning disability, and all sorts of things. And I was like, none of this was known about. He'd been all through services. Great that it's talking. I'm going to have to spend some time with the medical students, because it's quite traumatic actually listening to other people's terrible stories, and it's very traumatic. And we need to look after ourselves as well when we're hearing that. But what was happening was that his carers perhaps didn't know this stuff, and his dad was in a care home and was dying. Had some, I don't know what, dying of what, but they were trying to force him to go and visit his dad, and his dad's dying. And that happens all the time. And so we need to just be really aware about that. In the end, he decided he would go and visit his dad, but we need to be aware that we have a choice. Sometimes it might not be a good idea to go and see people because they could be their abuser. We don't know, but there's might be a reason for it. So it is underdiagnosed. There are some studies, I think there was one in Germany, where they only looked at clinic referrals, so they've already got a mental illness referred into mental health services, and then they screened everyone for PTSD, and then none of them were diagnosed. So 85% had it. It's incredibly high numbers. So just think about it. This is what I'm saying. Well, nearly everybody on your caseload suffers traumas, some kind. Well, we all suffer traumas as we go through life, but I'm saying they're, much more likely to develop PTSD. So this is about children. I've put in there about children. This is all children experience born traumatic event, 15 to 43%. It's really high. But how do we deal with that? How do we process that fear? How do we live with it? And if you have another and another. And I think one of the things that I found was the interoceptions. This is like if you've got a really good OT, which we used to have, we don't left, unfortunately, but you know, they can sort of teach these skills about yourself, who am I, what am I doing that's affecting things, and about your, just basically your self-concept, but in a much more just a realistic way. It's not a vague theory, it's a real thing that they're doing. So you have difficulties, people with intellectual disability have difficulty with that, the same for self-concept, also the physical things about who you are, where you are in space, you know, processing issues, so you don't perhaps even know where your arms are, or what you're doing, how you're standing, and difficulties with self-regulation. But again, whether this will turn out to be a separate thing, or if it's part of ADHD, which is very common in people with intellectual disability, can't express themselves so easily. Even if you've got verbal, you've got a lot of speech, you might be more repeating what people have said to you, or using set phrases, and it might be really difficult to express yourself. So in therapy, one thing that is common that's different to general therapy is about teaching, you know, I'm wondering if you're feeling really angry now, so you might have to go over and over about feelings, what it is you might be feeling now. We just talked about that. If that happened to me, I might feel really angry about that. So you try to teach them about what, or, you know, I'm starting to feel really sad. You get massive counter-transference feelings, which can be quite terrorising. I mean, this is just even in clinic as well. You don't have to be having therapy, but, you know, counter-transference can be really, really strong. And it's okay to say that I'm feeling really sad at the moment, and what you're telling me is so sad. I'm wondering if you're feeling that, because you quite often won't get the affect. You might even get the incongruous smiling. A lot of women do that as well with the learning disabilities. So yeah, these all make it difficult to process the trauma, and you get left with the fear, and you're reacting much more concretely. So I think these are the things I've talked about. So the re-experiencing can be concrete, so it wouldn't be necessary telling you how to touch that. Although, you know, eventually it might get there, but it might be a nightmare. It might be making an allegation, and you know, avoidance is common, not wanting to talk about things, but it is a maintainer. We talked about that. And get angry when you have to talk about it. But I would still say, like, you get a lot of benefit. So the therapist struggles. We've got a psychologist, and she wants to do talking therapies. But, you know, she said, I'm not getting anywhere, we're just talking about the weather. And I said, yes, but his behaviour and everything has changed so much, improved so much. You know, things, because you're making a connection, a relationship, and you're listening. You don't have to be talking about these events that happened 5 years ago to make improvements. You know, that's the, and sometimes we have to help the therapists keep going, because they just want to say, oh, we're not doing anything, I'm going to discharge. I'm saying it's working, things have improved a lot. His social skills are improved a lot. You know, he's able to get on with peers and in an appropriate way. So actually the benefits can be really major, although for the therapist to keep thinking, I'm not doing anything. I think some of that is the counter-transference feelings coming from the patient, that they're, you know, that hopeless and no good at anything, because you get a lot of that. Yeah. So yeah, that would be our job, is to keep them going. God, you did a great job. Improvements. Yeah. So yeah, persistent sense of current threat, you get that a lot. This is really common in admissions. People are really high risk of admission, or, you know, in your challenging behaviour pathway. If you look at why they're behaving like that, you know, they might be acute, they might be quite paranoid, and that could be part of PTSD, the sense of the threat. So it definitely has that, and I can say, because in the inpatient I can see it live a bit more, being much more concrete, and I can say, you know, the patient turning around and going, why do you keep staring at me, and stuff, going, I'm not looking at the corner, I'm looking at you, whatever. And saying, right, it's coming from this, and it helps that to keep working with the patient and not feel that they've done something wrong or be moved away, because that happens a lot. But it can lead to changing behaviour, so that's the other side of it. So I think I've talked about the difficulties, because basically we've got a lot more problems. Polypharmacy, that can be an issue. That might affect memory. You know, the other treatments, the other medications you're on for other mental illnesses, which you're likely to have. Nobody's going to get just with complex PTSD. That's what I'm saying. They're likely to have severe mental illness. They're likely to have physical illness, especially if they're older. You know, going to have a whole list of things wrong with them, and can only treat one at a time. You keep going back and back, saying, why is it still not well? And you get down to the trauma. Yeah, so this is one, so it is quite old, but I found it quite useful, because this is someone from USA clinic, and she said it's people with developmental disability, which I think is sort of aligns with ID. And they didn't come to her clinic with PTSD, they came with challenging behaviour, so they were all referred with aggression, violent behaviour, and she diagnosed all of them with PTSD, so 51 all referred, challenging behaviour, all diagnosed PTSD. Wasn't complex PTSD then, but I think they would have had complex PTSD, and the abuse was horrendous. It's horrific. I even had, when I read the case history, I even woke up at 5 AM re-experiencing reading that case history, because it's so horrific. And you know, that is trauma that I suffered from reading about it. We've got to be aware that we can suffer trauma, and it doesn't have to be anything too big. And you know, that went away. I didn't wake up again at 5 AM, but you know, I could say that was really hard to read that paper, and it's very difficult to keep working in this area. A lot of people do leave, because you do suffer secondary, tertiary traumas. Even if you're supervising therapists who tell what's happening in sessions, who've never seen the patient, you can get trauma symptoms. And there, I only read about it, and it was years ago that it happened. So this can happen to all of us. And yeah, like I say, it's really, really severe traumas that had happened to these people. And but what she was talking about was this sort of treating each layer. I found that helpful. So it is about, you're going to have a lot of complex problems, and not just one on its own. Have to sort everything out one at a time, whatever that might be. And one of the things she did say here was about staff taking people to visit their families, and the families were the abusers, but forcing them to go because they hadn't known about this or thought about it. You know, so you've got to make it a safe place, and that's something, there is some other research about that attachment. The first thing is about safe place. You're not going to go anywhere until that person is living in a safe place. You need to create a safe environment for them to live in, which is what I was talking about earlier, about working with the network and trying to reduce staff leaving all the time so they can build relationships, feel safe. Then you can start doing the other things, but that is a really important one, that you need, that they need, that sense of personal safety. And so if you're constantly being taken to visit your abuser, you're not ever going to get out of that feeling of threat, danger, shame, guilt, everything. So yeah, and she did talk about comorbidities and medical illnesses, but also difficulties that she'd had with physicians refusing to treat people with learning disabilities, you know, even though they've got mental illness. And when I was the first consultant, certainly had that, but not so much recently. We seem to get a lot more support. But it's if you make the diagnosis in the first place. So, so I found that quite interesting. And she was talking about this things you've got to do everything, and it also includes supporting staff because it's difficult working with these patients. Staff get traumatised, threatened, abused, or you know, suspended and investigated. So we have to support the staff. We have to create that safe environment. And of the ones who did receive all the treatments that she suggested, they did improve, but there were a lot of barriers to the others getting that treatment. So it wasn't that it didn't improve; they just didn't even get all those treatments. The others. Yeah, so I've added that in separately. I don't know why, but there's a classic psychotherapy paper written by Symington, who was at the Tavistock, 1981. So it's a long time ago. So it's good to read it, and it's the first patient with a learning disability that he'd ever seen, and he was saying that actually that man made a lot of improvements, but he himself felt that he wasn't doing anything, so he discharged him. So it's the same things I was talking about before. But then he does reflect at the end of the paper, why did I do that? And I think that's something, you know, that we all have to think about. People actually do improve a lot by just quite small things that you can do. It can be, but it can feel very hopeless. I think that's what I'm trying to say. You've got to try and stand back. Sometimes we need a colleague or a friend to help us stand back from it and say, actually, they've made a lot of improvement. It really helped them. You know, it might only be 1 or 2%, but over time and different things, if you treat 6 things, you know, you might get 12% improvement. So but only each thing you don't notice it as much because they're, you know, each small thing. So maintaining that hope and standing back, you can see that people do improve. Yeah, and that was just something about autism, about there's some research saying that people with autism suffer, you know, the things that are traumatic to them are different to things that are traumatic to us. And so much more trauma and much more PTSD in people with autism. So then you add it on for autism and ID and ADHD, you've got a much more, you know, you've got much more reasons why you might not be able to process that event that's happened to you and remain afraid and remain, but it would be much more concrete. So, I mean, you know, there are difficult things that you need to do. I was thinking about, there was a patient that's transferred into my area suddenly overnight. When you get that, I'm always suspicious. And, you know, there are a lot of things happened, and care home was closed down. So I thought, okay, I'm going to do a Google search on this care home and see what's happening. And, you know, they basically had to close down, they've been abused, various things. Oh no, this person never suffered anything. You don't know. You just don't know. They can't tell you they suffered anything. One of the things that he said, and when they went with that had happened, was one of the carers knew that a patient was triggered by static on the radio. So they kept turning the radio onto static. And it's like torture. That's what I was reading it, thinking that's torture. It might not be torture to me. I don't know, it might be, I don't know, but they knew it was torture for that person, and yet they kept doing it. So these are the things that happen that you wouldn't necessarily be able to like prosecute for that one thing. I think people were in the end prosecuted, but you know, they say, oh, this guy that's come to you, yeah, nothing's happened to him. We don't know. you just don't know, and you've got to be aware of, you know, what, if you're living in a home like that, probably something did happen. Yeah, so considering everyone, I'm not saying that for everyone, but 5 minutes. Oh yeah, so I just did this case example. This is it's 15 or 16. Sudden anger, aggression. This is, I've talked about it already. Dissociative seizures, self-harm, attempt to strangle the office staff. But I mean, came in because he tried to kill himself, throw himself off the bridge in reception, went to the general adolescent unit, and while he was there, kept putting staff in headlocks. I kept having seizures, being sent to the general hospital, given more and more anti-epileptics, and he did have a learning disability, and fortunately was in our local area. They tend to get admitted more. We shouldn't, because it's a national service, but they do. So yeah, once we'd worked on the epilepsy, reducing his meds, and he wasn't as drowsy, and he wasn't having dissociative seizures. After 6 months or something, he could say he was having flashback. He'd been sexually abused when he was 14 in a toilet pub, and he was having a flashback to that. And when I said to Mum that about, oh yeah, that did happen. Oh yeah, he did get worse after that, but she'd never sort of put anything together. That didn't come in with that history. He actually was psychotic. That was the other thing. He was very psychotic, but they did treat that in the general adolescent unit. But he was talking that had 2 men talking about him, opposing voices, but he was only in the notes. He couldn't remember any of his time, but I could look through the daily notes that they'd written on the adolescent unit, and the psychologist documented it. But he had loads of physical health problems. His teeth were horrendous. And all this we did while he was in, but also we had to have a circumcision while he was with us. But he was quite old for that. They're saying normally it's not done before he was young, you know, 16. So he's quite old. But he also had, like, his feet were horrendous. They just, what he'd been doing, but they just kept getting infected all the time. They had big calluses on them, and yeah, and he wouldn't eat any vegetables. Then as he went over the 1.5 years, so I'd say he would eat hidden veg. He knew they were hidden, but he would eat them. He blended it up, and then eventually, by the time he was discharged, he was eating actual veg. So, you know, a lot, I mean, you know, there was a lot of change just going from like when you come in and don't, you know, actually he always did see, and said that he's on so much epilepsy now. But these are all the things that we did, and did end up, we have a low stimulus environment, basically with our medication, so we can make everything very low stimulus and individual. But I did try and treat him on ADHD meds, and it became more psychotic, and then in the end we had to use Colladine, which seemed to help. His mum was like, oh, this is wonderful. I didn't notice it too much because he was so incredibly impulsive. Like, he'd have no episodes for, you know, months, and then someone standing by the nursing office, someone opens the drawer, there's a pair of scissors there, and he just went in and grabbed it. He just couldn't help himself. It's like, after, I don't know why I did it. He was absolutely fine. But it's so impulsive, so it didn't really work for that. But it's not wonderful treatment. I'm not 100% sure about Colladine, but that was the best that we could do. And a lot of adolescent nowadays, I've actually really think Colladine is wonderful. And they're trying to do a bit of a study in my favourite about it. I'm not sure. Have we finished? Yeah. I believe that. Yeah. So that, well, the key point there about the emotional numbing, don't discharge people. And if they're not upset and they're telling you about trauma, that's because they're more severely affected. Okay. Oh, and this is read my so I'll spell it. I've written a chapter in this book. It's a psychotherapy book. And it's coming out in September with round editions. That's what it's for, just for psychotherapy, what it is and why it matters. But okay, and that's some other research. Skelly, and my job.
Thank
That's
you.
it.
So the thought, especially as we're all trying to make our services more trauma informed. Okay, so next we've got a journal club. Maybe. Do you have a little comfort break? No, that's not.
It was really good. I'm so glad I made it back.
I was thinking so many patients as we're looking through, you know, we have patient in ICU, COVID, about like psychotic breakdown, but actually very much. Getting better with our therapy, and it'll tiny bit. So, yeah, that happens. Wow. Yeah.
And also part of it was it's about character and self-build
We were tempted to that is odd. Somebody would see yeah, that's always the key. Because it's scared, that's very, very easily. And it's just scared. I'm gonna be too roaring in this. They have a disability. Yeah, those just like standard like on Western, like these words and the same, like die. It's allowed to work. It's like the big five down saying that. We ended up. Yeah, they got so.
Okay, I've been start 2 weeks now, yeah. What do you want to take it off? Yeah, no, really, so. Alright, yeah, already stuff.
Right, we're gonna get started again. So Ivy Lim, who is, can you remember where you're ST at the moment?
Havering.
Havering.
Yeah. No.
Who's ST4 in Havering is doing a journal club presentation on therapeutic farm.
Yeah.
Ivy,
I don't think I'll take the full, but I'll speed it up anyway. Okay. So here's my journal club. I had wanted to do it on animal assisted therapy, but so I could convince Ian and Laura for me to take my dog to Hackney Learning Disabilities for my clinics. I'm not buying a cat in addition, but Open Athens, unfortunately, would not allow me to open the paper. So I've had to settle on the Gaia Therapeutic Farm instead. So it was a prospective study on multidisciplinary care efficacy, and I think it was published in about 2024. So this farm, I don't know if anyone's had a chance to look at the paper, it was sent around. But essentially the farm is a non-profit organisation which was created in 2009. It's in the suburbs of Tunisia. It sounds a little bit like the day centres we have here, but maybe with a few more therapeutic activities on offer. So it has daycare and also like socio-professional integration for children and young adults between the ages of 6 and 30. So quite a wide range. They have lots of activities, including pet-assisted therapy and also horticulture, agricultural work. They even did like animal breeding with rabbits and things like that. And it's supposed to help with meaningful applications. So it helps with physical health, which is good for your physical work for your physical health, helps with the rehab process. It's that socializing in the community and also like hobbies. and it has led to structured treatment programs. So a quick look on the Gaia Therapeutic Farm. These are just some photos I managed to find on the website. So it looks very wholesome. You've got lots of outdoor space, even some alfresco dining, a nice greenhouse for the patients to do their horticultural work. Some weird looking prison building, which I imagine houses some chickens or rabbits. But I don't think that's the learning space. So yeah, it all looks very therapeutic compared to some of our inner city day centres in London. So some of the activities on offer seem to be green care, social and therapeutic horticulture, some animal assisted interventions. So that's small animals like rabbits, dogs, cats, but also the larger animals like horses as well. There's care farming, so like helping on the farm as well with the landscaping, which is supposed to be quite therapeutic and help with like rehab. And also green exercise, so essentially exercise in the open space. And then wilderness therapy, which all sounds very rustic. So the theory was that there's therapeutic benefits both in doing the agricultural activities themselves and also contact with animals. Who has a pet in this room? Who feels happier when they're with their pet?
That doesn't like me.
Oh yeah, I understand that too. So yes, the therapeutic benefits of being around a tiny creature who you can't speak to, and yet you somehow understand each other. So there's been lots of studies on pet-assisted therapy, not that I could open it, but it promotes socialization, decreases inhibition, it imparts pleasure, it kind of teaches you the needs to like look after others and others to look after you. And it's been shown to have improvements in psychiatric disorders and also people with intellectual disability, especially those with behaviours of concern. And also the relationship with animals, it increases feelings of security. They're very loyal most of the time, maybe not cats, but certainly dogs. And there's an increased probability of regular exercise. I'm not saying that the patients who attend the day centre will take them out on walks, but certainly in the open space, they'll be like playing and getting their heart rate up. I looked a bit at the equine therapy that they offered as well. So equine therapy, apparently horses are very good at mirroring human reactions and they're quite empathic. So the interactions of the people with intellectual disability with the horses can increase confidence, build trust and empathy, help with social skills, impulse controls. Animals, you can't pull their tail, for example, otherwise there'll be a negative reaction. And also there've been papers saying that just the mere position of sitting on a horse can make people who are maybe physically or mentally disabled feel less so because of the positioning and feeling, you know, like less disabled in themselves. So the aim of the paper was to assess the therapeutic benefits of therapeutic on-farm management. So it all passed the ethical considerations. They obtained informed consent from the parents or legal guardians of the study participants as well. The method, it was a prospective cohort study across 10 months of the school year at Gaia Therapeutic Farm. And they looked at data from T0, which was at the beginning of school year, and then they redid the questionnaires and observations at T1, which was the end of the school year. So all the participants received an intervention of 10 months of regular MDT care, and we'll go through to talk a little bit about what that involved. It wasn't so prescriptive, it was more personalised to the patients and what they would benefit from. Which could limit the generalizability of the paper. The inclusion criteria, it was a mix of CAMs and also young general adults, so between the ages of 6 and 30. They had to have a diagnosis of isolated intellectual disability, or they had an associated autistic spectrum disorder. They had to attend the farm regularly, they had to have informed consent from their caregivers. And there was also a preferential inclusion of people from lower income families. The exclusion criteria were people who missed more than 20% of the days across 10 months and people who dropped out of the study at any point. So the assessments, they had a mixture of people from the study itself. So they had one single researcher, a psychologist and a co-author. And then the caregivers also had to complete a questionnaire. So at T0, start of the study, and at T10, at the end of the study. So all pretty normal in terms of the socio-demographic and clinical data. They looked at marital status of parents, education levels, how many children are in care. And this is how they defined your socioeconomic status based on like how much in proportion to the guaranteed minimum wage for the country. They assessed the competency, so that was the researcher assessing the patient. So they did it on a scale of 0 to 2, whether they had not attained, emerging, or fully achieved the competency, and they were a range of skilled movements, language, autonomy, and academic performance. So in terms of assessing language, they seem to look at the verbal and non-verbal expressive language score. So the word usage, phrase/sentence usage, appropriate gestures. So there's rather than something very prescriptive, it could introduce some subjectivity well, he's basically reached it. So across the different assessors, there could be some variability in scoring. And they also looked at the understanding of verbal language, so your simple and your complex orders. Gross motor skills, it was running, jumping with both feet, throwing a ball, and then the finer ones, so holding a pen, cutting with scissors, lacing shoes. And that's quite important in terms of the therapeutic farm, because if they're doing agricultural work or horticulture, it takes a lot of planning, fine movements, dexterity to plant things, water things, and things. So in theory, you should see an improvement across the 10 months in these skills. They looked at hygiene, so your ADLs, your capacity to eat independently, your continence, and whether you were able to dress independently. And they also looked at the pain and spatial and temporal orientation. So by that, they meant distinction between left, right, times of day, understanding the body schema. And then this was the academic requirements. So kind of stuff you'd expect to be learning in school across the year. There's also an observation of their social capacity. So observation of group rules, group games, capacity to wait one's turn. These are all important because often when people don't kind of comply with these social rules, then they might be diagnosed with like behaviors of concern and end up on medications if they're too irritated. There's also the autonomy for different activities. They did greenhouse horticulture, cuniculture, which is kind of like breeding of like animals and like rabbits, I think in this case, and also cheese making, which sounds quite nice. So they assess this with before and after training with the help of a Likert scale. We had a look at the child behaviour checklist, which is the questionnaire they gave to the parents to complete at the start and at the end of the school year as well. So this is a scale for global assessment of emotional and behavioural disorders and social and academic competencies. They were scored by the parents and provided with a standardised description of these disorders. They chose this because given the psychomotor and developmental delays in individuals with intellectual disability, and also to obtain an independent assessment from both the care team and also the parents. But it could, of course, introduce an element of bias. Depending on the parent you they'll either mark you really, really harshly, or perhaps some people are quite soft, so you might have unrepresentative scores. So for the total score, you look at the internalized behaviors. So kind of your emotional state, your mental state, any anxiety, depression, somatic complaints. and then your externalization. So that could be your behaviors of concern, your aggression, and non-compliance with the rules of, like, say, games or sociologically. You might not be able to see this. I just thought it'd be helpful to see what the child behavior checklist looks like. So it's a scale. There's some statements, and you've got to mark it from 0, 1, 2, 0 being not true, 1 being somewhat true, and then 2 being very true or often true. And it'll be behaviors like can't sit still, restless, hyperactive, or avoids looking at others in the eyes. So lots of simple statements which parents just have to subjectively mark where they think their child is. In terms of MDT care, so it wasn't very prescriptive, but people would come in and they would be put into either the special needs education group or the professional training group. It was the full range of people from 6 to 30, and they would attend Monday to Friday. They weren't residential, so they would come to the Gaia Therapeutic Farm and then go home afterwards, which introduces the element of are the parents continuing things of what learned at home, or are they kind of relapsing into behaviours they used to have? Both groups received speech therapy, occupational therapy, computer training. They had art workshops, they had psychotherapy, and they had pottery workshops, zoo therapy with small animals like rabbits, equine therapy, as we've discussed. So lots and lots of things on offer, and it would just be whatever the patient could engage with on that day, rather than a set schedule of things. For statistical analysis, they looked at the frequencies of to describe qualitative variables. They looked at means, standard deviations, and extremes to describe the quantitative variables. And they looked at the progression of competencies and the evolution of symptoms. So by that, they looked at the child behavior checklist, comparing it at T0 to T1. So if there was improvement, you would see the scores reduce, and they assess whether they had a statistically significant impact. And they also looked at your change in delta scores of competencies. So with the observer competencies, if things have improved, your score should be positive because you're now reaching more 2s rather than 0s. So 0s being not attained, 2s being attained. So in the end, it's a very small n number. So they had 50 participants at T0, but then subsequently by T1, 4 was excluded, 3 because they were absent for more than 20% of the time. 1 participant died. So in the end, there were 46 young children and young adults with learning disability between the ages of 7 and 30 years old. There was a male predominance, so there was 29 males compared to 17 females. The median age was 17.7 as well, and the majority of participants were at a low socioeconomic level. Hopefully you can see some of that table. It's always quite difficult putting tables into PowerPoints. There was a spread of the severity of intellectual disability. So actually most of them were quite severe, but then so 34 participants, but there were some people with mild or moderate learning disability. They also looked at the parental involvement as well. So that had a good spread of insufficient, satisfying, and excellent. So between 14 to 16 participants in each of those as well. So that will be the impact of continuing the therapies at home. Looking at the comorbid diagnoses, most people had an intellectual disability of unknown etiology, so 41% of participants, but there were also people with Downs, cerebral palsy, epilepsy, and ASD. Of all of the participants, they said that 43.48% were on pharmacotherapy, of which 11% were on antipsychotics and 13% were on anti-epileptics. So they looked at the mean subscores. So you can see here from T0 to T1, the internalizing behavior, so your mental state, how you're feeling inside, and that showed an improvement according to a child behaviour checklist. So from a mean of 55 down to 48.96. The p-value is not 0 because that's not possible. So actually it was that the p-value was so small that the software couldn't put the full number onto the table. So it's quite statistically significant, the difference. And you get the same with externalizing behavior and also the total scores as well. We'll look at the competencies as well, but in summary of that, there's an improved understanding of verbal language, gross motor and fine skills, and kind of your autonomy, your ADLs, social integration. But not every single difference in the progression competencies was statistically significant. So you can see that the gross motor skills, the fine motor skills, statistically significant, which is to be expected given the activities on offer at the farm. But despite the intervention, the verbal and non-verbal language was not, there's a difference, but not statistically significant. And actually it went from 1.978 to 2.087, so not a huge difference numerically either. So observations from the farm, what they found was there was improved emotional expression and relational behaviour. There was improved verbal and non-verbal communication, but as you could see from the table before, it was perhaps not statistically significant, but maybe visually they could see improvements. With certain activities, they saw improved and externalized behaviour. So that would be behaviours of concern, aggression, and how they relate to other people. And they seem to think that participants who are perhaps presenting as quite excessively shy with anxiety, depressive symptoms, in the therapeutic environment of the farm, they seem to be able to take more initiative and vocalize themselves a bit more. So perhaps it's the confidence of socializing and interacting on the farm itself. And I think the other things we've discussed at various points within this presentation. So looking at the confoundings in this study, of which there were quite a few. So the implication of parents in the treatment process was evaluated according to their willingness to follow the psychoeducation. We saw quite a few parents who were insufficient or only moderately engaging with the therapeutic plan at home, which could have impact on the scores because obviously they're only on the farm for about 8 hours of the day. This child behaviour checklist was spoken about how it's self-reported by the parents, so it could introduce an element of bias depending on how harshly they mark their child, and also after 10, they know what they're looking for in the study. So that expectation of things should improve because we're doing all these therapeutic activities could cause them to give unrealistic scores at the end. And also the child behaviour checklist is actually only validated for people, for children between the ages of 6 and 18. But as we know, people on the farm go up to the age of 30. We also looked, it's not a randomised controls trial, it's a prospective study. So we didn't have a control group, there was a small sample size as well. There weren't structured treatment plans, so we couldn't say specifically what part of the farm itself was beneficial to each domain. So perhaps a randomised control study in the future would be more helpful. It also had a wide age range, so there are CAMs and adult psychiatrists for a reason. There's lots of different needs, different presentations, so perhaps generalising to people from the age of 6 up to the age of 30 is not best in terms of clinical practice as well. So in conclusion, I thought the farm has shown, like, you know, observationally improvement in these people with intellectual disabilities, improves their behaviour, their motor, cognitive and social skills. However, the study itself had lots of flaws. It was a prospective study. It didn't have a control group. It's a very small sample size. So it could be a stepping stone to more specific studies in the future. I'm not sure. Do people think is it's something we could replicate in London itself? Yeah.
It's Sweetly Farm.
Oh, okay.
Yeah, patients who go there.
Lots of patients go to the city farm.
Yeah,
Mm,
love it.
Steady.
yeah.
Yeah, they get so attached to it.
Mm.
And the families love it.
Yeah.
Marriages are-
Yeah.
But yeah, it's a really lovely.
Yeah, so yeah.
And we should have more.
There's big thing about
Mm.
doing research and showing the benefits.
There's amazing therapeutic communities as well, in like
Mm.
northern London,
Yeah.
Hertfordshire, and
Yeah.
Camp Hill.
Mm.
Yeah.
Yeah, there's residential units. So I work in ELFT, so we get a lot of the edge of London boroughs. So in Essex, there's huge facilities like residentials where there's one gentleman who's like 30, morbidly obese. They weren't really coping with him in a supported living with like 6 carers at any one point. So it kept breaking down. And we've just sent him to this residential placement, which has a swimming pool on site, has horses and stables, has a lot of like animal assisted therapy. And they've said his behaviors have improved so much. He's lost 5 stone in the past 3 months because he's so much happier himself. So I think we should move to more these rather than these stuffy day centres with a tiny courtyard and no one's really engaging.
Really nice as well in Camden.
We get it, you have money in Camden. But yeah, any questions or for Pritesh? Yeah.
Did they comment on how much it costs compared to us mainstream? You know, like, for example, if we did it here,
Mm,
comparing it to like whatever people on the east do get, it's quite expensive
mm.
and quite formalized. Don't know as well.
I think the problem is with these facilities, as soon as you get an NHS contract, the prices just get 10 times, like shot up 10 times. So I think in terms of cost effectiveness, it might start off quite cheap, but eventually it'll get quite expensive. Especially here, land is really expensive in London. And a lot of people don't own the freehold. So then they're buying a leasehold and then paying on top of that. And obviously that cost is passed on to the people paying to attend the centres. But this was in Tunisia, so I imagine the like costs of running it and the utilities is probably much cheaper. Yes, Lee.
On the other hand, the carbon costs for a project like this would be far lower than a typical built centre.
Yeah.
And the NHS like towards net zero, we're going to need more than other things. Help, really sorry about
Yes, definitely.
Control at all for where the kids were before they went to the farm? Were they in a residential place? Were they at home? Were they living in tunits in tiny flats?
No, so they didn't look into that data, but I guess they looked at the socio-economic background of these children, and they tried to offer it more to the people from the lower income households. They didn't say where they were before, but I imagine given the large age range of people from 6 to 30, they were probably in some sort of educational facility. And then they sorry?
Were they all from tunits?
Yes, yeah, from the suburbs. So I guess the barriers would be you would have to get yourself to the farm itself, so you'd have to have some sort of transport links.
They weren't countries.
No, I mean they could be. We're just making assumptions.
The data.
Oh, was it?
Most all from cities, with like 4 who
Oh, okay.
Just from a critical appraisal perspective, I think you also have to be careful about assuming that all the observed benefits were as a consequence of the farm. Children and adolescents and young people and even people like me are still have a degree of neuroplasticity, and we change from T0 to T1 to T2. So you can't just assume, although it is a wonderful idea,
Mm.
that all of these benefits which were observed
Mm.
were as a result of the farm.
Mm.
And also farms can present with risks
Yes.
as well. So I don't know if there was any measurement of accidents or any adverse
Mm.
things on the farm.
Yeah.
Um,
Yeah.
Yeah.
Certainly something to.
To really evaluate it, you
Yeah.
have to have some sort of
Yeah.
comparator.
Yeah, and I imagine replicating it in the British system would be quite difficult with our health and safety laws, and especially as if once there's one accident, a lot of facilities become more risk adverse or take away the animals completely. So just need to.
Sorry, there are
Yeah.
equine therapy places.
Mm.
Well, I know of one only because I know the person who owns it, but and she runs it for children with
Mhm.
LD and autism. There's a therapy centre where they come in and out.
Mm.
She just set up a school as well.
Oh, that's lovely.
Children, but it's also they also do the equine therapy as part of the school
Mm.
curriculum
Yeah.
on the same site. But yeah, it's getting much more used. Probably.
Yeah. Yeah. That's definitely good. Yes.
On that point, equine therapy is probably the most researched green intervention that someone at ECL is doing systematically. So in terms of the critical appraisal, it's useful to know that some of the subsections of the programme there
Mm.
will have an evidence base, and
Yeah.
more so in children, young people rather than people with IV. But that was interesting to hear about the
Mm.
perhaps proprioceptive effect of
Mm.
being on the horse.
Yeah.
And yeah, I think also we do often think about risk with horses, but there's the counter argument that if you do a proper risk assessment and then you empower someone to take the responsibility in that moment,
Mm.
that can actually be therapeutic in
Yeah.
itself.
Mm.
But yes.
Yeah. Very good comment. Oh, Ian, I think you were.
Well, I think it's great, and and there's obviously you can theorize about all these different ways that a therapeutic effect might be mediated.
Mm.
Of course, I do agree with Eileen's critique of it, but this is the first study I have seen from Tunisia, and I think we should be welcome that that there is some sort of systematic evaluation. Of course, yeah, we can criticize it, but
Yeah.
but yeah, I think that's good. And then on the financial model, I have to mention finance these days, but the city farms are, for example, are like third sector grassroots organisation.
Yeah.
And I think
And they're self-sufficient as well, aren't they?
as well, and actually income generating a bit, and they I went to a party. We went to a party. But yeah, so this sort of pluralistic financial model is much better, and then stops people sort of taking advantage.
Yeah.
NHS and stuff.
Yeah, the capitalism. Yes, Pritesh. Yeah.
Following on, you could study something like this. What would you do next? Would you like condemn to the spirit
So I think it's quite important to do more randomized control trials, which might be quite difficult to find the specific interventions and their effect sizes. From reading around it, they looked at, so obviously I'm a dog person, so I looked at some studies on dog assisted therapy and their control, rather than not having a dog, because that's very obvious and you can't blind it. They had a robotic dog and they looked at the which some of them actually, so I visited day centers and they had fake cats which kind of move and they feel like cats. It's all like
Make nice cats if they were robot.
it was like 300. Apparently it cost £500.
Manipulation.
Yeah.
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 Cats and dogs, yeah, the liaison, stage liaison. Oh, yeah, they sit in the office They're too close to them, they're turning them over.
They do the dog therapy, pet therapy.
So yes, maybe we should do a randomized control and get all of our pets in.
Do we really think that these sorts of things require this kind of medical model of evaluation?
Mm.
I guess the point.
Have we not aimed to provide really great lives for people? I mean, I think we didn't talk on sustainability and nature, and I mean, I think we have a really good idea of things that make up a good life.
Mm.
And I just wonder sometimes whether putting in
Mm.
sort of academic methods of evaluating things, whether it's
Yeah.
really necessary.
But yeah, I mean, I just think, this is, either academic, you read them into these things, it's gonna miss the value that it gives to someone's life. How do you capture that? Yeah, but at the same time, how do you fund these things, unless you've got some sort of tangential, like, this is what's better because of this, and I'm not saying that's right, but like, that's the world that we.
These terrible places like Enfield, like giant warehouses or like converted houses where people live for hundreds of thousands of pounds that is what it is, whereas you could have this, but we kind of, the only thing we can advocate for sometimes is to study it and show some evidence.
For example, would you have to do a study to show that going on holidays is good for people?
I think to get funding for it, you probably do.
Yeah, well, we don't know.
Just in terms of like commissioning things, as you know, we're hearing all the time about services closing down, day services being decommissioned. I think we often forget to do a bit of research, you know, kind of very common as evaluation of how these things have a big impact for people, and perhaps maybe through the concept, having a bit of
Because I
data is
suppose
helpful.
if the scores hadn't gone up,
Yeah.
I mean, we'd still probably think that this was a really good idea for people.
Mm.
I think this is, I mean, sorry, Helen. I think this is marketing for them, but they're not an estate agent, they're a small organisation, it's probably a charity in a country that doesn't normally release that many papers, and we're talking about it, so I think that's the reason why it's published, really, more than the actual academic, you know, system. It means that it's, you know, it's opened up to a new, you know, a new demographic.
Because the risk is if the result is not that robust, or you can really criticize the method, or you can say, oh, but the positive result is not long lasting or something, you could give admission to not on different things, right?
We always such a good, do we need to show them?
But it's not, well, but they're
But then let's do
tangible
the
benefits
benefit,
that you
yeah.
can't just measure with a form.
Well, maybe it should be qualitative rather than this, you know, here are the numbers, you know, this is a piece of quantitative research, and maybe I just don't capture. Capture it. I think an LG just shows that it doesn't have to be something deep. This is just, it's a great fun, and there are many things that can be measured, because one, there's structure to go in, and there's a lot of people happen to do. Two, they will have these rates, like for example, these are activities on the farm. We do feel that, it's a lot of things that I think we overlook in LD, and I think this kind of study, although it's very small and all of that, it just shows it. It doesn't have to be quite big. I think it's the impact on the patient and the quality of life that they have from doing this kind of thing. I think that's a way to sell it, basically.
I think this is a good example of, like when you read papers, how our own biases can influence our thinking and how we support some studies and how we don't. So when we all believe in, we all like, I support, I like it, I was saying, but we all talk about it in a very positive way because of our own biases.
Yeah. Because, so if the intervention had been Melrose, Like putting a whole lot of people on a horrible antipsychotic drug. Like we would all say, well, that's a terrible study. So to be aware of our biases in terms of how we positively evaluate something, something.
I think in terms of research, it also depends on what the aim of the intervention is. So this is just a generic therapeutic arm. So you're kind of nature adjacent. And I suppose they realise that will then put people in the better place to engage in activities, etc. But if you were to be kind of comparing, say, nature-based therapies, doing psychodynamic psychotherapy on a bench rather than in a clinic, comparing that to ketamine-assisted psychotherapy, you know, there's a more clear aim of the nature in that thing. So that could be an RCT, whereas this, as it's so holistic, less specific, it's harder. But I think some people would argue that you'd want to show that nature can be a medical intervention with medical outcomes, so that it can be being promoted. But as I would say, it's so easy to miss the outcomes with that.
And finally, Ian.
Yeah, I think to settle all this, we need to go on a fact-finding mission. Tunisia.
A new conference. Fabulous idea. And on that note, we will finish.
Thank you, that was great, and lots of discussion, and we're still ahead of time, which is amazing. So, Lynn, do you want to, but it's 11:47, do you want to start at 12? Yeah? And just a reminder, there isn't any lunch, so.
We say,
Yeah, my work is really hard for. I just, I used to think actually that, just consciously now again, yeah, very, very different. But also, she was getting bigger and bigger and bigger.
Yes, context.
And then I got this, like, this kind of picture I heard, but then her like this. Going into baby face. She never did baby voice. Yeah, he's like, yeah. So somebody. Yeah. That's what it's like. I think it's fairly sad. We never hear it. It's really positive. I think I'm gonna study about that would be a very and he was like, and she's from things, and it was all said my parents part about their last holiday. Did nothing about it. She said my hair was
Yeah.
Also like passive
Yes, and then. I've seen so I think
I wonder if I went back there, how many of them came signals for that?
But I No, when I'm going on Monday, I'm about to bring them. I never have them. Like, no way. Stop We're gonna start again. Okay, so we've got Liam here, who is our lovely ST5 working in Camden at the moment, only for another month. And he's going to present a case that we found quite difficult to deal with, but yeah.
Yeah, thanks, Jata. So I'm going to speak today about Luka. He's not a professional footballer, but he is from Croatia, and sometimes I just kind of think of him because of his hobbies and kind of frame and things like that. It's pretty spurious, but at least now you have someone to imagine as we speak about him. So Luka's a 23-year-old man of Croatian Bosnian heritage that grew up in the UK, who lives in supported accommodation in Gospel Oak. He really likes sport, whether that's running, ice skating, swimming, playing catch, trampolining, you name it, he loves it. And he actually has competed competitively with swimming in the past, kind of with neurotypical people. So he had real strengths in that area in childhood. He also loves travel, going into big cities. He really likes movies, gardening, and singing. He really dislikes waking up early, personal care, and boredom, which I think we could all be appreciative of. He has a diagnosis of a mild, moderate intellectual disability and childhood autism. So there's not much jeopardy in this case presentation because I'm going to tell you the potential diagnosis quite early on, but when I joined the team last August, I was told that there was a 4-year history of functional regression, and the most likely diagnosis at that stage was catatonia. In August, he was requiring full support with his ADLs in the supported living. His communication was limited to single words or short phrases repeated back from what a carer or a parent might say to him in a whisper. He was requiring a lot of prompting to engage in any sort of activity, whether that's something he enjoyed or whether it's something he disliked. But with a lot of prompting, he might engage in some of those activities, even skateboarding, ice skating, which I think we probably don't see too often in the intellectual disability population. Mum's theory, kind of, as well as mainly agreeing with the catatonia, was that Luka may have been doing this through rebellion, as she'd noticed that when no one was watching, he may dress himself or sing or dance in his bedroom. As of August last year, psychiatry were coordinating the case, but there wasn't any treatment prescribed. I don't think my predecessors here, so there could have been good insights there as well.
Oh, Ian.
So just going back to the start of Luca's time with our service, he was referred in early 2022, so he would have been 18-ish coming from CAMS. I think it was a bit of a late referral. And the referral from the CAMS service was of social withdrawal, a loss of skills, and an increase in aggression directed towards his mum, who he was living with at that time. The timeline's quite curious because whenever you speak to resident staff or when you speak to mum, they speak about the major symptoms which coincided with the COVID-19 pandemic, so 2020 to 2022. But actually, if you dig into that, there'd been kind of minor symptoms in the 2 years prior while he was still at school. So he was having some difficulties at school, he was being bullied, and he'd started to withdraw, enjoy things less, engage less socially. But I think because there was an identified trigger, the bullying and the kind of end of schooling was in sight, there wasn't so much concern raised in that regard. However, from 2020 onwards, within 6 months of lockdown, he'd reportedly lost motivation to do anything, whether that was kind of dress himself or get out of bed. He would only talk if he was angry or kind of expressing a strong dislike. His appetite decreased and he lost weight. He was sleeping with kind of a more disturbed pattern, but for far longer, so more than 12 hours at a time. He stopped masturbating, and at his day service, which he'd usually enjoy, he was noted to be more socially withdrawn. So at that first point, after the first psychiatry assessment in CLDS, the proposed diagnosis was depressive episode. Sertraline was prescribed, as well as making recommendations around psychosocial interventions. And that was prescribed for over a period, I think, of 8 months or so, 10 months, at a dose of 50 milligrams. The dose couldn't be increased because he was having physical side effects which were tolerable, but you wouldn't want to have pushed it further. So he was getting a fine tremor, loose stools, and mydriasis. However, after 10 months or so, it was decided that there hadn't been a sufficient response, and mum was becoming progressively concerned about the mydriasis. He had been seen by an optician who'd said that there weren't signs of something like glaucoma, and the team knew that it would be a known side effect, even though it's quite rare with sertraline. Just as an aside from that, does anyone know what alternative antidepressants you might use if someone's shown mydriasis with an SSRI? I didn't know when I started this. Not so it's a very it's an uncommon side effect of SSRIs and venlafaxine, but you could use mirtazapine. Though in this case we were treating depression, so that would have been an off-label use anyway. Alongside sertraline being prescribed, Luca moved from his mum's house into supported accommodation. However, things didn't improve except the aggression to mum, where there'd been a physical change, so that was less likely to happen, and he wasn't being aggressive to staff. 2 years into the presentation, when he was reviewed by a consultant, they noted physical slowing, so psychomotor retardation, long periods of immobility, as well as freezing, the reduced communication, as I've mentioned before, echopraxia in addition to the echolalia, and requiring physical prompting or even kind of completely controlled movements by staff to do things like eating, getting changed, using the bathroom. He was scored highly on the Bush-Francis rating scale, so at this point, the diagnosis was proposed as catatonia associated with autism. But we couldn't quite, that's the royal we, I suppose, identify a causal trigger. It wasn't thought that he was particularly anxious. It wasn't thought that he was depressed. The social changes had been put in place, but actually the presentation was worsening. This is still at that kind of, at that early stage. We're jumping back a bit here. So when he was referred to adult LD services, an annual health check was requested or prompted, but it hadn't been completed. Blood tests had been done a year on, and nothing abnormal was detected in terms of a kind of routine screen. An interesting point to pick up on there is that mum's a very strong advocate for Luca, but to the point that at times it has obstructed care. So though we were prompting to see the GP, prompting to do phlebotomy, there were quite a lot of hurdles to get over with just doing those simple investigations. A social story was used for this instance of phlebotomy, and I just found it really interesting going back to the notes and seeing what mum had emailed following the tests. So the social story was used. Seemingly there was no issue at the GP surgery, but I suppose as we might expect, mum reported he'd had a reaction after the blood test and had thrown a fit when he got home. Mum was very glad that the blood tests were normal because she'd been saying, you don't even need to do blood tests. I know that this is a psychological issue. So she said, I really hope this test helps us prove that organically he's healthy. Organically is the name of the Waltham Forest green intervention. Organic, because it's in the Lee Valley. There we go, we got it. So yeah, she was very pleased that there was no physical health cause identified. And I think this kind of enhanced her feeling that our kind of medical approach and to do tests was unnecessary and kind of strengthened that barrier to us doing more medical investigations down the line. So I suppose at this point, before I dive into his past psychiatric history, it'd be useful to hear, is there anything anyone wants to pick up from on what we've gone through? Tessa.
When he was having, you say he's lost skills. Is he still doing sport and activity during this time? And how is his function when he's doing that?
Yeah, so that's really interesting. He would still engage in those things that he really liked, but let's think of, say, trampolining. From the picture, from the notes, I think it would take a very long time to get to the trampolining setting. And even though he was there and would usually love it, you'd almost need to kind of move him to the trampoline, get him onto the trampoline, maybe even initiate the bouncing movement, and then he could get into it and would enjoy it. But then the same thing would happen as the activity comes to an end and moving him off and back to...
Those ball skills and stuff had gone.
I imagine catching a ball would have been difficult because of needing support to initiate the action. But yeah.
And I think his mum described going to the swimming pool and he needed so much encouragement to get into the water, whereas previously he really loved it. And then he wasn't really swimming, he was just standing there.
Being in the water.
Yeah.
Yeah. Yeah. Tash?
What's the timeline for the rate of getting works? Is it action works or
I think it was a steady and progressive decline over around 2 years. So those were the pandemic years. But if you looked back at the 2 years prior, there were probably a few kind of early warning signs. But that could could so easily have looked like straightforward depression as well. Yeah. But I think 2 years to a point that then plateaued for a fair while after that.
Yeah, just what I've recently heard, but in the last year, this concept of autistic burnout as a differential for depression. I've become concerned that perhaps as psychiatrists, we often lean towards diagnosing depression when autistic people, in response to often environmental or sensory or other stressors, have this almost coping strategy of shutting down. And then sometimes we can add in medication like SSRIs, which can cause side effects which make matters worse. So I just wanted to highlight that piece of learning that I've come across in the last 2 years, is this important differential between depression and an autistic burnout, which can really mimic depression in terms of the length of time. So it can be many months, and it's often an almost coping response to just things not going right.
Yeah. Do you think there's a pattern of triggers that would help you more early on discern whether something's likely to be autistic burnout? You know, are we thinking, you know, specifically of the
thinking more carefully about that differential at the beginning, whereas I think our training pushes us towards thinking more of a depressive episode.
And because you want to be able to do something
Yeah.
make it better.
Yeah.
You want to go for something that might be easily treatable with a tablet before.
And tablets for autistic people can be really sometimes difficult.
Yeah.
Wrong.
I guess we can often forget that the cognitive load and these transitions and stress and things like that. You know, the threshold for burnout is much lower.
So he had lockdown.
he left school, then had lockdown, then moved house.
And moved house, so he has loads of reasons to be overwhelmed.
Yeah, because I've seen several patients at this transition point from college that where it's shut down, it's happening and a real regression in skills, and somehow there's no return to baseline. The recovery doesn't seem to happen, or at least not within the time period that I've seen them.
Yeah, it can take a long time. Yeah.
Thank you. It'd be good to get more information on that. We could have a session.
I'm sure it's not. I am on a learning trajectory with autism.
Yeah, I often get asked to see people who've been admitted to the mental health ward. So this is people without a learning difficulty, like having an autism diagnosis, and they'll have been admitted and like given a diagnosis of a severe depressive episode, or sometimes mania actually, because it can also come with like a lot of agitation. And yeah, get asked to go and give an opinion.
Thank you. So just going back to Luca's kind of background, so he was diagnosed with autism and associated communication difficulties at 2 years old, so that's quite an early diagnosis. He was known to CAMS in his late teens because he was referred with behaviours of concern, primarily aggression towards mum. And I think it's quite helpful just to understand him to dip a bit deeper into that. So I've got written down here a few of the triggers from his PBS plan, but how do I scroll here? Where's my mouse? Sorry. So when Eurus lashes out at his mum, she can get emotional. This provokes him even further, and behaviours can then escalate. Another trigger. When family discuss Eurus's needs, they tend to do this in front of him. This can trigger violence, likely because of a sense of him feeling excluded. If Eurus isn't reassured, he can lash out. For instance, he'll pause an activity, seemingly looking for guidance and input, and if he doesn't get this, he can get frustrated. Number 4, having to make a decision or choosing something that he's not actually happy with. Or number 5, not understanding what's happening next. So we can see some of those quite clearly fit into our understanding of a person with autism, also someone that can't communicate their needs so well or is excluded, even though they may be able to communicate their needs. And this was managed, I think, moderately well with the PBS input by the point he was handed over to CLDS. He'd never been prescribed regular psychiatric medication, but at the time of that transfer to our service, he had been prescribed promethazine briefly, though a 25 milligram dose caused sedation without actually reducing the frequency of the incidence or the intensity. So that was only trialled for a couple of days. Mum in the past had also given homeopathic medicine and has suggested using cannabinoids, but I don't think those discussions were ever kind of in depth. Luca has no past medical history and is generally quite fit. His family history, he has a younger half brother from his dad's current relationship who has autism, but in terms of what his dad reports, the autism is far less kind of impairing or evident in this half brother. His parents, his older sister and youngest half sister, have no psychiatric diagnoses. As I've mentioned, currently he's living in supported accommodation in Gospel Oak. He has one-to-one staff input during the day and whenever he goes out into the community, and he attends the Harrington or Hartington gardening scheme, which he loves. So he does that twice a week. Mum and dad are separated. They're not on good terms. He sees his mum many times a week. So, for example, they'll go to her church where he really enjoys the singing, or they'll go and do a sporting activity or just walk around central London. On the other days, he goes out with his one-to-one support. He sees his dad once a week. Dad acknowledges that mum is the kind of primary carer, but I think he would like to see him more. And they have gone on some quite successful holidays in recent years, just him and dad together. He rarely sees his siblings, I think because of the challenges that Luke presents. Mum and dad seem to kind of block him from seeing them. So quite early on, I think. So yeah, dad was violent towards mum, and they separated quite early on in his life. And then unfortunately, mum's second partner was also abusive towards her, and Luca would have been around for all of that. And I think parents, have never really found any resolution to that. Though have remained living quite near each other and giving input to Luca. Luca himself attended a mainstream primary school and a SEN secondary school. As I said, he had notable strengths in sport and would go to singing lessons. So it's not simply that he enjoys kind of singing along with people. He had some kind of technical ability in it, I suppose. He's described before this episode of illness as a happy, easygoing person, and also a people pleaser, which I find, quite interesting, and we'll come back to that later. Before this illness, he would speak in full sentences and he could do all his ODLs with minimal support. So that, I think, demonstrates the level of change that we're seeing now. So jumping around a little, but we're now at kind of late 2022, so after a period of assessment with the Adult Learning Disability Service, the withdrawal of sertraline, it was decided to do lorazepam stress test. So this was attempted over a period of 2 days with consultant input, attending his residence, observing the results, and then providing telephone follow-up as well. So 1 milligram, and then 15 to 30 minutes later, 2 milligrams was given on the first day, and then 2 milligrams given the morning of the next day. There was only a slight improvement in the Bush-Francis scale, and after those 5 milligrams, the test had to be abandoned because Luca was so sedated. So clearly it's quite hard to do the Bush-Francis examination if someone's really sedated, but also you can tell quite quickly that someone is not coming out of the catatonia. After a period of months where I think there was some quite careful negotiation with mum around managing expectations of what may happen when you give psychiatric medication and the pros and cons of that, there was a decision to trial risperidone at a low dose, just in case there was a psychotic diagnosis that had preceded or caused the catatonia. This was only trialed, I think, for a month, because after 2 weeks, Luca presented as very flat, unresponsive to others, more passive than usual, and very slowed down. It was taking up to an hour to eat a meal, even with full hands-on support from his staff. And there wasn't any benefit seen to the mental state. I'm not sure how to understand this, but the epipraxia ceased. Perhaps that was simply because of sedation. Yeah, rather than a positive medication effect. So I think at this point, everyone was probably feeling quite stuck. Mum, I believe, was feeling resentful towards psychiatry because she is not the most medication willing person anyway, and there'd been 3 attempts at providing medication for treatment. Ali.
And so I was just wondering, I mean, between the story of on the trampoline, where he couldn't initiate that movement, he could continue it. And if that even a small dose of risperidone, it seems quite extracorporeal symptoms, thinking about vomiting, both seem really like facing anti that.
Yeah.
Had a scan.
He's not had a brain scan. And I think it's a good point to pick up on, and there's a kind of been a learning point for me whilst putting together this presentation, which maybe we'll come back to, that kind of picks up on that point. But I agree.
We did refer him to neurology,
Yeah,
because of that, and they reduced to see him.
Yeah, I think that's the next slide. Referral to neurology. Yeah, so he was referred to neurology, and they simply said, we've reviewed the information provided and do not feel that the patient needs to be seen in clinic at this time. I think just generally, we probably get a lot of this, not necessarily just with neurology, but with other secondary care services. And a pattern I've at least experienced is if you ask a GP to refer someone to a secondary care service, that referral will be nowhere near as good as a referral we will write, because they're not seeing the patient as regularly as we are, and they're doing one of those something in guidance referrals, which only are a paragraph, and then you get almost an automatic reply. So this was an advice and guidance reply from neurology to the GP.
I wrote the referral for the GP.
Okay. But I think that, but then the way it works, that doesn't go to the specialist. So if you can find.
But I phoned neurology up to find out how I made the referral, and that was what
That's the only one.
Yeah, so we similarly had a patient with this kind of catatonia presentation, and basically we just referred him for an inpatient assessment at Queen Square, panning. which was really helpful to be able to speak to anybody. So they did the tests, although they didn't actually do the blood tests, and we wanted to do the last time challenge and all of that. But yeah, that's one way to do it if the family are in agreement.
Well, that's the thing,
yeah.
mum also does not want the neurology
Yeah,
referral.
I think that was again this, why do you think it's medical?
Yeah.
Yeah,
And an admission to hospital, no way,
Yeah.
you know. So.
Yeah, but this was a bit more palatable, I think, rather than the psychiatric admission and.
But she doesn't like the medical side of things either.
Yeah, okay.
Did you ask for a neuropsychiatrist from?
so we have now, yeah, Sash.
Why am I making me?
Yeah, good question, yeah.
But you had referrals made, but it sounds like.
Yeah, it's not, yeah, obviously you use the capacity act, the best interest decision, but where a mum is so against certain things, we do have to work with her and continue to work with her, so, and she does kind of play a massive part in his life, so it would be very hard to push something through without getting court protection.
Yeah, I have slightly, I know we discussed the statutory on like neurological tension. What I think there's still, the discussion is still very high on the list from you, and I at least had 2 people over the last 3-4 years, very similar losing skills, particularly when it comes to people losing their skills they have and declining skills, and then we know Catalonia is at least associated with the expression like mood disorders. Whether he had enough trial of 90%, I know he developed side effects. But that's what I think. I had not exactly the same, but similar woman in Down syndrome, mid pandemic, developed lots of years to the extension, even what we think. And I would have some considered California at that point, but just trial, we didn't develop any side effects, etc. He was like, but you can't compare that case to this one, but the depression is still.
Yeah, higher on the differentials for sure.
It doesn't need to recombine and capturing that. It's anything like RTMS thinking, so that's a short course down to assess.
Interesting, I don't think so.
No. But we do have it in the trust, so.
So this is still 2 years ago where we're at the moment. There's time to go, hope is not lost. So he had some OT input, and I think that was a really good idea at the time, because if you're thinking about initiating actions, completing tasks, to bring in a different kind of set of ideas was really useful. I don't think we have time to go into all of it, but I suppose the OT assessment found some features which we might see kind of typically in autism, irrespective of whether someone's also experiencing catatonia or not, but also things that you'd be far more concerned about. So they tried various things. So to start him doing these movements, which I certainly wouldn't be able to come up with, and I think are quite practical, quite logical. So for example, physical prompting or backward chaining, using a timer, letting someone do something first and then coming in if they can't do it next. Environmental changes like a mirror to help dressing. We have noticed that Luca can dance in the mirror now. So that's not exactly helping with dressing, but he does seem to enjoy having it in his room. And then reducing demands and regular movement and exercise breaks. So, but the OT found that really the global decline in skills didn't change at all with any of those attempted interventions, and this was over a period of, I think, 18 months or so. It was a long piece of work. So their kind of closing recommendation was to aim to improve quality of life and see what changes subsequent to that. And to be fair to the residential placement and to mum and to the social care team, since then, so this is kind of late 2023, there was more funding for activities, more one-on-one time, more trips into the community, more of the activities. And over that period, things did improve. So from kind of late 2023 to now, Luca's mobility moved and quality of life have improved, all through kind of psychosocial interventions. So daily trips out, daily exercise, or even twice a day exercise, more time at the gardening scheme, music therapy through a charity that I'd not heard of but sound really brilliant. Yes, yeah. It was, I think, 12 sessions in a group with some individual sessions as well. And I think the waiting list was 3 years or so. So he finished that this year and loved it, according to all accounts. But the family are now looking into seeing if they can continue something else privately, but the Nordoff Robins don't offer that option. The Bush Francis scores whilst I've been working with Luca were 8 when I first met him, and then 3 in January this year. So 3 is only 1 score above the screening at which you wouldn't bother to complete the rest of the examination. So that's a fairly good score. That being said, he is still quite slowed at home and still requiring a lot of support for ADLs, but in the rest of his life, things are changing. So he can have periods of hyperactivity. He can walk up to 30,000 steps in a day, trips into the city. His vocabulary and complexity of sentences is a little improved compared to a few years ago. But if he's upset or angry, he can speak with the fluency that he would have as a teenager, for example. And yeah, there are times when he's very motivated that he might dress himself, like getting unchanged to go swimming. There's a suggestion from mum and the staff that he works with that excessive demands can intensify the presentation. So if he's not expected to do much, he appears really happy. So for example, in his room alone, dancing and singing. When no one's too close to him, he may talk to himself quite cheerily. And when something changes that he doesn't like, so for example, he's out on an activity, he can freeze and then be very slowed for the rest of the day. If he's told he has to go home, for example. There's also been an increase in behaviours of concern. So for a long part of this year, there was kind of weekly episodes of the same behaviours that he demonstrated while he was under CAMS. So stamping, jumping, hitting a table, and being physically aggressive to those closest to him. Interestingly, but I suppose very understandably, considering what he went through in childhood, staff suggest that they see the most aggression towards his mum. So that could be kind of mirroring what he saw in the other males in the household. Sometimes staff have to go and collect him from activities with her because he's become so aggressive towards her. But curiously, mum says this is because he doesn't want to leave her, and actually not really much happened, and yeah, kind of plays that down. So there's quite a tension between the resident staff and mum about what's good for Luca and what's not. We've had more of Dad's input recently as well, and curiously he says that Luca is a good soldier when he's with him and therefore doesn't do any behaviours kind of out of what he'd expect of him. And Dad says that mum
making Luca, for example, wake up early to go to singing at church will be a big trigger, and that mum saying that Luca needs to be vegetarian even though he loves meat will be a daily trigger. So I think no comment there. But I do think that probably mum has taken up so much of our bandwidth that we've not worked so much with dad. And though some of the things he says are perhaps a bit shocking, there are also really interesting insights from him. One thing that's really helped with this recently is that a favoured member of staff at the residence has come back from an extended holiday. And when he got back, Luca said in his full voice, "I've really missed you."
Oh.
And really quite soon after that, the behaviours started to reduce.
It's been called rational gender, email and everything.
I think it can be to anyone because he mainly has male support workers and it can be to them as well. He has a female housemate in the residence as well, and there's never been any aggression towards her. But, yeah.
What does he say about it? What does he want?
Yeah, that's a really great question. So I think whenever a professional has met with him over the past 5 years, there's hardly been a word exchanged. So I've met him a number of times now, and he's comfortable with me there, but we still don't really get past a whispered hello and then any kind of echolalia to the things I'm saying. And I get the impression from the OT who worked with him a long time that they didn't kind of hear from him so much. But I think in future it might be that a talking maps could be quite helpful with his
voice, but not his.
Yeah. What would you like your diet to be? Things like that. Yeah. When do you want to wake up?
Yeah, I was actually going to say that the talking mats and different like input from speech therapy to work out, what's happening, and also if he is getting emotionally dysregulated, or there's some strategies, zones of regulation and things like that that people look at. The psychology and things like that.
Because I think
he's had psychology.
Yeah, he's got psychology.
He might have had SLT as well.
SLT collaborated with the OT for that period of work. Yeah.
Engaging well in music therapy, there's one minute
I couldn't quite hear you, sorry.
He was engaging really well with music therapy. It seemed to be doing really well. What's kind of
Yeah, I should reach out to them. I only got feedback via mum that for the first 2 sessions he was very restrained and shy, and then after that was so caught up in the music that he was just really enjoying it and engaging a lot. But I didn't get a kind of psychological formulation from them, but that'd be helpful. So kind of as of now, no new physical health concerns. We're still struggling to get annual health check blood tests done. So there's going to be a best interest meeting about that, because mum suggests he only needs bloods every 2 years, and actually even if 2 years ago it was good, does he really need it this year, for example? So yeah, there's going to be a best interest meeting about that. But as Sujata was saying, you really need to bring mum on side rather than just forcing Euros to have them, because that will cause such a kind of flare up in the tensions between professionals and mum. But in this instance, he was in clinic and the nurse was kind of working it all up and everyone seemed calm, and then just kind of the moment before mum said, "No, stop." Just so anyway, yeah, that's not the interesting part. So subsequent to Dr. Jonathan Rogers speaking to all of us about catatonia, I reached out to him and he was very pleased to take a referral, and I think that would be the case from any of us, regardless of borough, for the specialist UCL neuropsychiatry service where he's doing a catatonia clinic. And instead of meeting with Luca or meeting with Luca's mum, he just asked me to do a kind of review of the notes, and then for about an hour we spoke through the case, a bit like this presentation, I suppose. And then just in terms of logistics, he went away, did his own formulation, wrote up a letter which he then sent to us, as well as speaking to me about their recommendations. And I thought, if we've got time, yeah, that's kind of what we can focus on now. So he suggested chronic catatonia in the context of ID and ASD. You might say he's biased, but he gave fairly good reasoning. And just some interesting learning points from my discussions with him. So he was saying that chronic and mild presentations of catatonia are more common in people with ID than you'd see in the general population. Psychosocial triggers for the onset of catatonia to an outside observer might appear quite minor compared to in the general population. So it might just be a very small psychosocial stressor or disagreement or small change in circumstance, and then this kind of overblown catatonic response is what they've observed. And unfortunately, the evidence-based of chronic catatonia, as opposed to acute, in the general population, and then by extension in those with ID, is really poor. So if you've got a chronic catatonia picture, whether that's associated with schizophrenia or autism or depression, that's far harder to treat than an acute episode. He recommended that we do further investigations, so physical examination for focal neurology and skin and joint changes. So the skin and joint changes relates to lupus, which can be a rare cause of catatonia. So you'd be looking for the butterfly rash or a discoid rash or the whole long list of other rashes you get with lupus. He'd recommended looking at bloods for reversible causes. So thinking the thyroid, which we knew was normal back in 2021, bloodborne infections, B12 folate, and then Wilson's disease. So again, in that physical examination, you could be thinking about, are there any liver signs of Wilson's? And then he was recommending genetic testing, and that would be the whole genome sequence for Luca, but also his parents. Dr. Rogers suggested, like, the way you can try and kind of persuade parents is that you'll have some benefits. If there is a positive result, you've got diagnostic certainty of something that's been so unknown for the past 5 years. It could assist with family planning, whether that's for dad with his second partner, or Luca or any of his siblings in future. Screening for complications of other genetic disorders, if one were to be identified, and a rare possibility in the future of a disease-modifying therapy that could be identified. So I fed this back to mum and dad. Dad is very keen. Mum is kind of not totally against it, but wants to do her own reading. She's a bit concerned about how her data might be used, and I think that's entirely kind of fair, you know, if you've not had the discussion. So a full kind of consultation with a CLDS psychiatrist about that, I think, is probably what the next step would be. And then you can refer them either into the genetics service for them to do all the next bits, or we could coordinate the whole genome sequencing for Luca, and then his parents would get that done separately. Brain scan, as you were asking about, could be the next step, but let's just like turn the volume off or something. That might keep it awake. brain scans and EEGs, he said would come later, possibly, but at this point he was confident enough in the clinical diagnosis. I do think though, if Luca had turned up in A&E as a 21-year-old with these symptoms, that would have been the first thing done, and that would have been very helpful. But I think, yeah, at this point now, it doesn't seem so indicated. In terms of management, and I've just split this up here, both in terms of priorities and kind of intensity of care. So Dr. Rogers suggested the Sharwing behavioural approach, which I'll go into a bit more.
Well, Ron's very keen on that then.
I can try turning on myself.
Did Liam likes to sort of
While that's happening,
Yeah.
did he also talk about autoimmune screening or anything?
Yes. Did I maybe didn't write that down, but yeah. What did he say on that? I think it's just turned off, but turning it back on is up.
Actually, you did mention that.
Thanks, Shannon. I think certainly at an early stage you would do autoimmune. He didn't recommend it at this point. But yeah, I think it's a bit under as well. If we're doing blood tests for him after all these years, I think you'd, if anything is still to get indicated, you would do it. So there's the behavioural approach, which I'll speak about. Then there are medication options. So as Batica was pointing out, if you did feel like there is still an ongoing mood or anxiety disorder, then appropriate treatment for that would be the absolute priority. But we feel at the moment there's no clear signs of that type of illness. Amantadine or memantine are kind of novel treatments for catatonia, and I'll come on to them at the moment, but there's not the best evidence, and it's more helpful in acute catatonia rather than chronic. And then an lorazepam challenge would be indicated in some people, but seeing as Luca was so sensitive to the first, and again, this isn't so well indicated in chronic cases, it's more acute, the benefits are unlikely to outweigh the risks at this stage. ECT could also be helpful, and maybe RTMS as well, but Dr. Rogers felt that at the moment, as things are improving, and a lot of that improvement appears to be subsequent psychosocial alterations, the behavioural approach is best indicated. So this is the book which I think at least some of us will know about from other cases. Some parents, I think, see it as a Bible, and fair enough, because it could provide an answer to such a kind of distressing and impairing condition. So I've not read a whole book, but I have been sent this chapter by Dr. Rogers, and I'm happy to share it with the group as well, which is about the psychological approach to what they call chronic catatonia-like deterioration in ASDs. And the fundamental aim, they state, is to identify and reduce stress being experienced by the person concerned. And the way to do that is by restructuring the individual's lifestyle, environment, daily program, and resolving any cognitive or psychological sources of stress. Picking up on the wording there, so they call it a catatonia-like deterioration. And what Ali was pointing out earlier is that they also say that a subset of symptoms would be called a Parkinson's-like deterioration, but these all come under the umbrella of catatonia in autism. And they kind of point out that that is similar but distinct to chronic catatonia in schizophrenia, which is where all of the original research evidence comes from on this subject. The introduction to this chapter to give a background, basically explains how little evidence there is for any medical treatments for chronic catatonia. As I was saying there, lorazepam, not so effective. There's a case series of using lorazepam in chronic catatonia in people with AS